So I'm Andrew Quanbeck. I'm an associate professor in the Department of Family Medicine and Community Health at the University of Wisconsin. So colleagues with Dr. Weber and Dr. Brown, who runs ECHO, and a close colleague. My background is actually in systems engineering, so while I'm on the faculty in the Department of Family Medicine, I'm not a clinician. I've done research on developing and implementing digital health apps to support recovery that I'm going to talk about today. Sort of a line of research going back really almost, it's been about 18 years now. So I wanted to acknowledge the funding that supports the grants that I'm going to talk about today. Two studies, one completed and one ongoing from NIAAA, and then a small grant from DFMCH. I wanted to acknowledge and thank my co-authors and collaborators. I do have a financial disclosure to make. I guess the most relevant one is that I have a shareholder interest in Chest Health, which is a small business that markets digital health applications to the addiction treatment field. I also provide consulting on digital health implementation through a nonprofit organization called the NIATEX Foundation. So I think for this audience, I can probably go through this quickly. You all know it's alcohol use disorder is highly prevalent and harmful. Again, I have been doing research on digital health apps to try to increase access to evidence-based treatment and prevention for substance use disorders, and with a particular focus on alcohol use. So we developed, I'm going to talk about a system called HS, which was designed for AUD recovery. It's built around self-determination theory. And so this is a picture of David Gustafson. As I mentioned, we've been doing this for a long time. So the Apple iPhone came out, I think, in June of 2007, and we our research center put in our first NIAAA grant to study the use of apps for alcohol use, supporting alcohol use recovery in October of 2007. So we were really on top of this, one of the first research labs to study the use of digital health for alcohol use, and published the first study in May of 2014. We did a clinical trial of around 300 patients. These were patients with severe alcohol use disorder who were exiting 90-day residential treatment for alcohol use disorder. And compared to patients in the control group, we saw a 57% reduction in risky drinking days. So this is one of the first digital health apps that showed effectiveness in a randomized clinical trial for any condition, let alone alcohol. So it was a big deal when it came out, and I've been kind of looking at adaptations and applications of this system ever since then. So I'm going to cover a couple of different projects. So again, we have that first study was really focused on severe alcohol use disorder. We know that at a population level, there's about 30% of the population, and even more in Wisconsin, that would have some indication of problem drinking, either binge drinking or drinking above recommended limits. So there is, this first system was focused really on people with severe alcohol use disorder. But we had ideas that perhaps we could reach a greater segment of the population by adapting the system and putting it out to a broader population with mild to moderate alcohol use disorder. So this was a research grant that was focused at UW Health. I think everyone probably knows UW Health is the academic medical center connected to the University of Wisconsin. More than 720,000 patients a year. So this is a large population to potentially intervene with around alcohol use. So we worked with stakeholders from UW Health to adapt the HS app. Trying to learn, well, what would we have to do? The original HS app was very, laser focused on abstinence and sort of designed for people with severe alcohol use disorder. So we designed it to be kind of more broadly applicable to patients who just had a desire to reduce risk of alcohol use, sort of progressing down to more severe stages. So it was built around the whole health model, which is something that our department embraces in clinical care. It's how the Center for Wellness at UW Health does health coaching. And this just shows some of the features of the app. So you see the whole health circle of health is kind of the foundation and the home screen of the app. And then it has, features for communication, both with the study team, with other members of the research team, and potentially with other people in the community or in the study. So what we really wanted to learn from the perspective of a health system is if you're going to implement a system like this, you can do it a whole number of different ways. This shows a spectrum of kind of varying levels of human support for behavioral intervention technologies, which is what we call apps like this. So traditional care is just a human delivered intervention. So that's, pretty self-explanatory. And then if you're going to incorporate some technology, you can either do it as like an adjunctive or a guided bit or a fully automated bit. So the way to think about this is, what level of integration do you want to have with the clinical care team? Fully automated bits would be sort of analogous to apps that you could there's a number of apps out on the App Store around alcohol use that, people can just download and use on their own. But the other systems, you can go all the way to like having it fully integrated with your medical care. So this is a big unanswered question. Digital health apps are out there. They're not very well integrated into medical care settings at this point, but there's a lot of interest in studying this and learning best how to do it. So the first project I'm going to talk about is to understand how varying levels of human interaction affect the ways in which this the Tula app works. So we tested 3 different digital health support models. The first one was self-monitored, a low-touch model, kind of like, just downloading the app and using it independently. Then we had a model where we provided peer support from a community organization. And then we had a model where we tested it with health coaching delivered one-on-one by a registered nurse. So this was something called a hybrid type 1 implementation effectiveness study. We also are doing cost effectiveness analysis to understand what's the optimal level of human touch required to implement mHealth most effectively. And our hypothesis was that basically, the more intensive human touch that is involved, you'll have higher effectiveness, but we also want to look at sort of the trade-offs in terms of cost effectiveness and the potential to scale within a large population. So I kind of mentioned this before. These are the 3. This was a randomized controlled trial, patient-level randomization. Patients had a 1 out of 3 chance of being randomized to either the self-monitoring group, the peer-supported group, or the clinically integrated group. So again, just fully unguided use of the app or having peer specialist support, discussions moderated by peer support specialists. The clinically integrated group had, in addition to use of the app, support by a health coach, and up to 3 one-on-one health coaching sessions. These were done because the study actually started. We started recruiting at almost the exact time that COVID broke out. All of the health coaching sessions were done via phone. They were not in person. So the inclusion criteria, again, we're trying to kind of zero in on, the mild to moderate alcohol use disorder population. So they had to have an audit screening score of 8 or greater, or respond yes to at least 2 questions on the DSM-5, or report moderate to high risk drinking patterns, which would be more than three drinks on any single day, more than 7 per week for women, 4 drinks on a day, and more than 14 drinks per men. So these are just NIAAA recommended limits. So people who reported more severe alcohol use were not eligible for this trial. Early on, we realized, and probably for a patient like we just heard about, an app is not going to be sufficient. So if they screened severe, we referred them to medical care. And then, we didn't. Psychotic disorder was terminal illness and acute medical problem requiring immediate hospitalization or other exclusion criteria. Our primary outcomes were percent of risky drinking days in the last 7 days and quality of life using the PROMIS Global Health, Physical, and Mental Health Scales. So this this is the consort diagram showing our randomization. Again, we recruited a total of 558 participants for this study and randomized them. So about 185 in each of the 3 groups that I mentioned before. This shows the follow-up rates, which were, pretty high, around 75. But they did range pretty significantly from 55% follow-up at 12 months to 75% follow-up from the clinically integrated and self-monitoring group. So that's something I'll talk a little bit more about later, because that was sort of an unexpected pattern that we found. So just a little bit of information on the study population. I think the thing, there's a lot to take in here. Largely a female, about 2/3 female, sort of middle-aged. So I guess sort of representative of the case that we saw in some ways. Fairly highly educated. We're centered in Madison here, so we get, a majority of the participants had some type of higher education, so not totally representative of the population. And then the breakdown of severity, most had mild, about 2/3 mild, and about 1/3 moderate alcohol use disorder. This is, again, it's probably easier. I'm just going to talk through some charts that show the results here. I guess I will say that we saw a significant reduction across all groups in the level of risky drinking days. It was about 40% overall at baseline, and it reduced to about 20% at the end of 12 months. So significant reductions in alcohol use in all 3 models, but we didn't see any significant, or not really significant differences between the groups. And I think it's easier to see that in these charts. So there was, you can see starting around 40% and going down to around 20%, but you see that all 3 of the groups track pretty closely together. So we didn't see a lot of difference in effectiveness based on the level of human interaction that was provided. And then this does show that one thing we did see is that quality of life of mental health did improve significantly for patients in the clinically integrated group. Those are the patients who are getting, or participants who were getting one-on-one health coaching. So that was the one thing that we saw in the quality of life domain. This shows the patterns of use over the 12-month period. I think one thing that's important for context, so starting at, everyone had to, log in to get started. So it starts at 100%. And we saw that people were still engaged at about the 60 to 70% level after 12 months or after a year. which actually for mHealth apps is quite a high retention rate. The average or the modal number of times that people log in to health apps is typically exactly one time. So the most common pattern for apps is people use it once and never look at it again. So we did see pretty good engagement. I think the thing that's interesting to note here is that there's definitely a separation in terms of the engagement with for people in the health coaching group. So this is just what we observed. To summarize, across all three groups, we went from overall 38% to 22% at 12 months. So if you look at the across time, all groups showed statistically significant reductions in risky drinking days, but there was not a group effect. There was lower risky drinking days at month 12 in the clinically integrated group, but then we also had the lower follow-up rates. So we have to take that with a little bit of, it's probably more likely that people who retained or stayed in the study were ones who were doing better than ones that dropped out. So that's something that we have to take into consideration. Again, I mentioned that we did see significant improvements in mental health quality of life compared to the self-monitoring group for those in the clinically integrated group. We also saw the peer-supported intervention improve participants' mental health from month 3 to month 6. There was no effect on physical well-being that was seen across the groups. So limitations, this was a pragmatic trial with no pure control group. To do that, you'd have to have a sham device, which is basically UW Health wasn't interested in having patients, do that. So we can't really say that we didn't have a pure control, so the reductions could be just due to a number of factors. Alcohol use was self-reported. Again, we plan to do coaching and peer mentoring with in-person components, but it all had to be done remotely due to COVID. And we had a relative lack of diversity among the study participants, being largely white, female, highly educated. But this is sort of typical, a pattern of uptake for integrative medicine interventions like we tested here. At least that's kind of the people who tend to use these. So that's who we ended up recruiting. So the implications, we're still kind of exploring this. There's not a lot of interventions available for AUD within medical care settings. SBIRT is there, but I think SBIRT has had sort of mixed effectiveness, or implementation has proven to be challenging for a long time. So this might be a possible evidence-based intervention for patients that they could access pretty easily, depending on the implementation model. We don't really know if you reduce, 16 percentage point decrease. We're talking about roughly one less heavy drinking day per person per week. How much is that worth? I don't know. You could argue about that. And I think it's just, those are the results that we report, and we have to try to interpret, how important that change is. We are thinking that based on the results, it might make sense to offer the self-guided version of the app to all patients, or if they want to reduce alcohol use, and provide options for health coaching due to the potential improvements in mental health and potentially peer support. The thing with peer support is it's pretty difficult to get something like that stood up and running because of the group nature of the intervention. Health coaching was pretty simple to add to the self-guided use by just assigning a health coach to work with the individual. So we're exploring those options with leadership at UW Health, but it's still uncertain exactly what the future will hold for this app. So I wanted to just briefly mention that's certainly relevant to the case study. We are currently doing a study where we're kind of going back to the more severe end of the spectrum here, and studying this app in a population with alcohol-associated liver disease. And we're seeing a lot of increases in the burden of alcohol-associated liver disease, especially among women. So, this is something that we want to be on top of. Alcohol abstinence is the only intervention to substantially reduce morbidity and mortality in this population. So again, this iteration of the app will be kind of going back to the original HS and designing features that will make it suitable for a population who's dealing with alcohol-associated liver disease. There's really a gap in ALD patient care. I think things are changing, especially at UW-Madison, but the standard of care, if you had reached the point where you needed a liver transplant, was, the health system would tell a patient to go to AA, quit drinking for 6 months, and then come back, and then we'll reevaluate for a liver transplant. So we are at UW-Madison, had started an ALD clinic to provide more comprehensive support for patients, so they're not kind of left to try to quit drinking alcohol on their own by providing medically managed support. So this study it's currently ongoing. We actually just recruited our 100th participant. It's a collaboration with Henry Ford Health System in Detroit. So we're doing it here in Wisconsin and Detroit. So we'll have kind of different, a different population in Detroit, presumably. We're testing an adapted version of the original HS app in patients with ALD. This again is a type 1 hybrid effectiveness implementation trial with patient-level randomization, and we're seeking to recruit 298 patients. But this is strictly a one-to-one intervention versus randomized controlled trial. So we are trying to demonstrate the efficacy of this app in a controlled study with this population. And results we won't know for a couple of years, but we want to provide every available kind of support we can for patients with ALD. It's a growing problem, and really looking to potentially set a new standard of care for ALD within healthcare settings. Through the leadership of people like Randy Brown and Jessica Mellinger at the university or at Henry Ford Health System.